Okay, let's unpack this. Imagine a single health problem so widespread, it's projected to affect over 130 million adults in the U.S. alone by 2035.
Wow, that's huge.
It is. And potentially costing more than $1 trillion. We're talking about ischemic heart disease, basically where the heart isn't getting enough blood.
Right.
And today, we're doing a deep dive into its most effective surgical solution. Coronary artery bypass grafting, CABG.
Our mission today really is to cut through all that complexity. We want to deliver the essential insights from a comprehensive look at this really vital area of medicine.
Okay.
We're going to connect the dots for you, from the fundamental way your heart gets its own blood supply, right through the incredible history of how this surgery even came about, its effectiveness today, and the cutting edge innovations that are constantly reshaping cardiac care.
So much going on.
Exactly. By the end of this deep dive, you'll have a much clearer picture of what's truly at stake and the remarkable strides that have been made in, keeping hearts healthy.
And why should people care?
Well, this knowledge is designed to empower you, whether you're seeking personal understanding, maybe some professional context, or you're just, curious about one of the world's biggest health challenges.
Okay, sounds good. So let's start with the heart itself. It's this amazing piece of engineering, right?
Yeah.
And its plumbing system is incredibly intricate.
It really is.
Most people know the heart pumps blood to the body, but it also needs its own dedicated blood supply to keep working.
Absolutely critical.
That's where the coronary arteries come in. They're the heart's lifeline, basically, delivering its main blood supply.
And they're the very first branches off the main artery, the aorta, right as it leaves the heart.
Okay.
Typically, there are two main ones, the left coronary artery, the LCA, and the right coronary artery, the RCA.
So the layout's important.
Crucial. The left coronary artery, often just called the left main, is short but vital. It quickly splits into two major branches. Think of it like a main highway that forks immediately. One fork is the left anterior descending artery, the LAD. The other is the left circumflex artery, or LCX.
Ah, the LAD. I've heard that one called the widowmaker. Is that because it's so important?
Absolutely. The LAD is, foundational. It runs down the front of the heart, supplying a huge portion of the main pumping chamber, the left ventricle.
The main pump?
Yeah, and the wall that separates the two lower chambers. It's considered the most important surgical vessel because it feeds over half of the left ventricle's muscle.
Wow.
So blockages here are particularly dangerous. They can quickly lead to widespread heart muscle damage.
And the other one, the LCX?
The LCX, that one wraps around the side and the back of the heart, supplies other crucial areas of that same left ventricle.
Okay. And then there's the right coronary artery, the RCA. What's its job?
The RCA comes from the right side, naturally. It primarily supplies the right ventricle and the back part of the left ventricle.
Okay.
It also has a key branch called the posterior descending artery, or PDA, runs down the back of the heart. And in most people, about 85–90%, the RCA is dominant. That means it supplies blood to some critical areas, including the heart's own electrical nodes, like the natural pacemaker.
So it's not just the big highways, but the tiny side streets too, the microcirculation. How does that fit in?
Precisely. These larger arteries on the surface, including the LAD's deep branches, they then feed into this vast network of incredibly small resistance vessels.
Okay.
These penetrate deep into the heart muscle, forming a really rich capillary system. These are the true workhorses. They're responsible for the actual exchange of oxygen and nutrients, right at the cellular level.
Wow.
This network is designed for efficiency. The heart muscle is incredibly demanding. It extracts over 75% of the oxygen it receives, even when you're just resting.
75%.
Yeah. So that means if the heart needs more oxygen, say, during exercise, it must get it by increasing blood flow. It just can't extract much more from the blood it's already getting.
Okay, so how does the heart manage that flow given such high demand?
Well, what's fascinating here is the heart's built-in ability to auto-regulate its own blood supply.
Regulate.
Yeah. Within a pretty wide range of blood pressure, the coronary arteries can widen or narrow to keep the blood flow to the heart muscle surprisingly constant. And during strenuous exercise, a healthy heart can crank up its blood flow significantly, sometimes 4 to 7 times its resting rate.
Incredible. How?
It's achieved through coronary vasodilation. The arteries widen in response to local signals, things like carbon dioxide levels, oxygen tension, and some potent natural chemicals like adenosine and nitric oxide. These act as signals saying, we need more flow.
And it's interesting, you mentioned most of this flow happens during a specific part of the heart cycle.
Indeed. About 60% of the coronary blood flow actually occurs during diastole. That's the heart's relaxation phase.
Why then?
Because during contraction systole, the heart muscle squeezes down so tightly on its own vessels that it temporarily impedes its own blood flow. So that relaxation period is crucial for refilling the heart's supply lines.
Oh.
But, and this is the critical part, this is where the silent threat comes in. The buildup of those atherosclerotic plaques, those fixed blockages, they significantly impair these delicate compensatory mechanisms, especially when the heart rate goes up.
Right.
This fundamental impairment, this inability to increase flow when needed, that's the very basis for exercise stress tests. They're designed to unmask underlying coronary artery disease, or CAD.
Because the demand goes up, but the supply can't keep pace.
Exactly. When those plaques prevent the heart from getting the increased flow it needs, that's typically when symptoms like chest pain, angina begin.
It's incredible how the heart's natural ability to manage its supply becomes so vulnerable to these obstructions.
Yeah.
It really makes you wonder, given how vital and complex the system is, how did surgeons even begin to think about fixing it?
Yeah. The journey to successful bypass surgery is, it's really a testament to some pretty daring medical innovation. Early pioneers were trying things before direct bypass was even a solid concept.
Like what?
Well, think about Arthur Weinberg, a Canadian surgeon back in 1950. He tried to revascularize the heart by implanting a blood vessel, the left internal mammary artery, or LAMA, directly into the heart muscle.
Not connecting it to another artery.
Right. Just creating a pocket and putting it in there, hoping it would sort of grow new connections and supply blood that way.
Yeah.
A creative idea, but not the precise bypass we know today.
Just hoping for new pathways.
Yeah.
Then came the era of actually connecting things up directly.
Yes. And that was hugely influenced by a game-changing diagnostic tool. F. Mason Soanes, he's credited with inventing cardiac catheterization in 1962.
Angiograms.
Exactly. It allowed doctors to actually see the blockages in the coronary arteries for the first time using x-rays. Being able to visualize the problem, well, that was revolutionary.
I bet.
Shortly after, also in 62, Frank SABISTON performed what's noted as one of the first direct CABG procedures using a vein from the leg. Michael DeBakey had a successful case in 64. But it was really René Favaloro at the Cleveland Clinic who helped establish CABG as a consistent, planned therapy. He demonstrated its viability with a large series of successful operations back in 1968.
But these complex surgeries, they wouldn't have been possible without the technology to support them, right? Like the heart-lung machine.
Oh, absolutely essential. John Haysham Gibbon developed and successfully used the heart-lung machine clinically in the 1950s.
What an invention.
It really was. This incredible device allowed surgeons to operate on a non-beating heart. It diverts the patient's blood to an external machine that oxygenates it and pumps it back to the body.
Creating a still, bloodless field.
Exactly. Which was crucial for the delicate work of sewing tiny bypass grafts onto tiny coronary arteries. Then came the advancements in cardioplegia.
Protecting the heart while it's stopped.
Precisely. Introduced by Sondergaard in 64 and really refined by Gerald Buckberg in the late 70s. This involves injecting a special solution to safely stop the heart and protect the muscle during the surgery.
And the field just kept pushing forward.
Oh, absolutely. In 1973, Subramanian pioneered beating heart bypass surgery, doing the bypass while the heart is still gently pumping.
Wow.
Then, by the 1990s, devices were developed to stabilize just small sections of the beating heart. This led to off-pump techniques, aiming to avoid the heart-lung machine altogether.
Right.
So today, we have this whole toolkit of approaches, from the conventional on-pump CABG to minimally invasive options, even robotic techniques, all aimed at tackling coronary artery disease. It's really a testament to how far medical innovation has come.
It's truly fascinating to see that progression, from those first daring attempts to stopping the heart and then even operating on a beating one again. Incredible ingenuity. But now that we understand the solution, let's talk more about the problem itself. What exactly is the disease that made these drastic measures necessary?
Right. The disease is atherosclerotic coronary artery disease, or CAD. And it's often a silent threat because it usually begins quietly, often quite early in a person's life.
Early on.
Yeah. It primarily affects the larger arteries on the surface of the heart, those epicardial vessels. And we know the key risk factors: high cholesterol, especially the LDL or bad cholesterol.
Yep.
Cigarette smoking, high blood pressure, diabetes, getting older, low HDL or good cholesterol, and a family history of early heart disease.
So a complex mix of lifestyle and genetics. What's actually happening inside those arteries?
At its core, atherosclerosis is really an inflammatory process that's closely linked to lipid or fat deposition.
Okay.
Think of it like this. The inner lining of your arteries gets subtly injured, maybe from high blood pressure or smoking, thing like that.
Right.
This injury triggers an inflammatory response from your body. And then cholesterol, particularly LDL, starts to accumulate in the artery wall, forming what we call plaques.
Got it.
And inflammation is involved at every single stage. From the very beginning, the initial fatty streaks to the full-blown plaque, and crucially, to plaque rupture. That rupture is often what triggers a heart attack.
And how do medications like statins fit into this inflammatory picture?
Oh, the development of statins was a massive game changer. These lipid-lowering drugs have significantly cut mortality in heart disease patients because they don't just lower the bad cholesterol, they also help stabilize these plaques. They reduce the inflammation within the plaque, they strengthen its fibrous cap, the outer shell, and basically make it less likely to rupture. And preventing rupture is key to preventing heart attacks.
So it's really not just about clogged pipes. It's more about these vulnerable plaques that can suddenly break open and cause huge problems. What makes a plaque vulnerable?
That's exactly it. If we connect this to the bigger picture, atherosclerosis isn't just simple blockages. It's this dynamic inflammatory process with specific weak points. A high-risk or vulnerable plaque is one that's prone to rupturing.
What do they look like?
They tend to have a large, soft, fatty core, almost like toothpaste, and a very thin, fragile, fibrous cap covering it. They also show more signs of inflammation and often have new, weak blood vessels growing within them. When this thin cap gets even thinner, often because the repair mechanisms are out of balance, it becomes highly susceptible to tearing or rupturing.
So a rupture always means a heart attack.
Not necessarily immediately, but it's the trigger. When a plaque ruptures, its highly clot-promoting contents are exposed to the bloodstream.
Right.
This can trigger a blood clot to form right over the rupture site. Whether it becomes a symptomatic event, like a heart attack or unstable angina, depends on how big that clot gets and if it completely blocks blood flow down the artery.
And what can trigger a rupture?
It can be spontaneous, or it can be brought on by things like extreme physical activity, severe emotional distress, certain drugs, even exposure to cold or an acute infection.
Okay, and for the fixed obstructions, the ones that just narrow the artery gradually, how much narrowing before someone typically feels symptoms like angina?
Right, so more than 90% of patients with stable ischemic heart disease have these advanced fixed obstructions. Now, for a long time, the body can compensate pretty well. You can have up to maybe a 60% reduction in the artery's diameter with minimal impact on flow. The artery might widen around the plaque, something called remodeling, and the tiny vessels downstream can dilate more.
Oh, wow.
But when the blockage reduces the cross-sectional area of the vessel by about 75% or more, that's when coronary blood flow is significantly compromised. That often coincides with the onset of exertional angina, chest pain when you walk up a hill or exert yourself.
And more severe blockages.
A 90% reduction in diameter typically results in resting angina chest pain even when you're doing nothing. This narrowing fundamentally impairs the heart's ability to get the increased blood flow it desperately needs during any kind of stress. This understanding of how atherosclerosis develops and manifests is just so crucial. It's clear it's not just plumbing, it's a dynamic inflammatory process with specific vulnerabilities. And this naturally leads to the next big question. How do clinicians actually diagnose this complex disease and figure out how severe it is in a specific patient?
That's the key, isn't it? Seeing the unseen, because like you said, it doesn't always announce itself loudly. How does someone typically present clinically when they have ischemic heart disease?
Well, IHD, ischemic heart disease, usually shows up in one of two main ways. Either as stable angina, that's predictable chest pain, or as what we call acute coronary syndrome, or ACS.
And ACS includes?
ACS is an umbrella term for more severe urgent events. It includes ST segment elevation, myocardial infarction, or STEMI, that's a major heart attack, non-STEMI or NSTEMI, which is another type of heart attack, and unstable angina or UA.
Okay, so anginal pain is the main symptom.
It's the primary symptom, yeah. Typically lasts minutes, usually feels like a discomfort or pressure behind the breastbone, the sternum, and it can radiate, spread to the neck, jaw, stomach area, or down the arms.
And it's triggered by?
Often brought on by exertion or emotional stress. And importantly, it's usually relieved by rest or by taking sublingual nitroglycerin, that common medication. Relief usually happens within minutes.
And when does that predictable angina become unstable?
Unstable angina is diagnosed if the pattern changes for the worse. If the pain is increasing, getting more frequent, more intense, lasting longer, or, critically, if it starts occurring at rest, that's a medical emergency, needs prompt evaluation in an ER.
Okay.
And it's really important to note that patients, especially women and the elderly, often present with atypical symptoms, not necessarily classic chest pain.
Like what?
Things like nausea, vomiting, maybe just discomfort in the upper stomach, or even sharp chest pain. The Women's Ischemic Syndrome Evaluation Study, the WISE study, found that a surprising 65% of women with proven ischemia presented atypically. This can make diagnosis much more challenging.
65%. Wow. So an acute myocardial infarction, a heart attack, how does that usually show up?
A heart attack, an MI, often presents as a crushing or severe chest pain. It might come with nausea, sweating, anxiety, shortness of breath. If the heart's pumping function is severely compromised, you might see symptoms of low blood flow to the body, dizziness, fatigue, vomiting. And a significant drop in blood pressure can indicate cardiogenic shock, a life-threatening situation, meaning a large area of heart muscle is damaged.
And complications can happen later.
Yes, critically, some serious structural complications like a hole developing between the heart chambers, a ventricular septal defect, or a rupture of the muscle supporting a heart valve can occur about a week to 10 days after the initial heart attack. This highlights a period of increased vulnerability even after the immediate event.
Beyond the patient's story and symptoms, what clues might a doctor pick up during a physical exam?
A careful physical exam can reveal subtle signs of atherosclerosis elsewhere in the body. For instance, examining the eyes might show changes in the blood vessels. Yellowish deposits around the cornea or on the eyelids can suggest high cholesterol. And listening to the heart sounds can provide clues. Extra heart sounds might indicate high pressures inside the heart or chronic damage. New heart murmurs could point to valve problems or even one of those dangerous holes developing.
Right.
And given that atherosclerosis is systemic, it affects the whole body, a thorough vascular evaluation is also essential, especially if we're considering surgery and might need to use leg veins for bypass grafts.
So those are the clues, but how do they actually confirm the diagnosis with tests? What's the toolkit?
For suspected heart attacks, or ACS, biochemical studies are absolutely key. We look for elevated levels of cardiac enzymes, especially troponin, which are proteins released into the blood when heart muscle cells are damaged.
Okay.
A basic blood count, kidney and electrolyte tests, and a lipid profile also give crucial information. A chest x-ray is important too.
What does that show?
It helps rule out other causes of chest pain, like pneumonia. It can also show if the heart is enlarged or if there's fluid in the lungs, which suggests heart failure. And before surgery, it helps surgeons spot other things, like heavy calcium in the aorta, that might influence the operation.
And the resting electrocardiogram, the ECG or EKG?
The 12-lead ECG is fundamental. It records the heart's electrical activity. It can show signs of a previous heart attack, ongoing ischemia or lack of blood flow, abnormal heart rhythms, or problems with the heart's electrical conduction system.
But it's not foolproof.
No, definitely not. It's important to remember its limitations. About half of patients with significant coronary artery disease actually have a normal resting ECG. And even during an episode of chest pain, the ECG can be normal in up to 50% of cases. So a normal ECG doesn't rule out serious heart disease.
If the resting ECG isn't always definitive, that must be where stress tests come in to see how the heart responds under load.
Exactly. Functional tests or stress tests are the most common non-invasive ways to detect if the heart muscle isn't getting enough blood flow when it's working harder, what we call inducible ischemia.
How do they work?
They involve either having the patient exercise, usually on a treadmill, following specific protocols like the Bruce protocol, or using medications to simulate the effects of exercise if someone can't exercise adequately.
Right.
While the heart is under stress, we monitor it using either ECG, ultrasound, that's stress echocardiography, or nuclear imaging, which uses radioactive tracers to see blood flow.
What do these different methods show?
Well, the exercise ECG looks for specific changes in the electrical tracing that suggest ischemia. Stress echo looks for new problems in how parts of the heart wall are moving areas that aren't getting enough blood won't contract properly under stress. Nuclear perfusion imaging shows areas of reduced blood flow directly. Each test helps identify if there's a part of the heart muscle that's starving for blood when oxygen demand increases.
Beyond stress tests, what about a resting echocardiogram? Is that useful too?
Oh, absolutely. A resting echocardiogram, just an ultrasound of the heart while the patient is at rest, is essential, especially for anyone being considered for surgery.
What information does it give?
It provides detailed images of the heart's structure and function. We can see how well the main pumping chamber, the left ventricle, is contracting. That gives us the ejection fraction. We can assess valve function, see if the heart chambers are enlarged or thickened, check for blood clots inside the heart. All this information is crucial for surgical planning and predicting the patient's long-term outlook.
What role does CT scanning play, especially in visualizing the arteries themselves?
Multi-detector computed tomography, or CT, has become really important, specifically coronary CT angiography, or CCTA. This can provide incredibly high-quality, detailed images of the coronary arteries non-invasively.
What can you see with CCTA?
You can see blockages, how severe they are, whether there's calcification, the exact course of the vessels. It's particularly good at ruling out significant coronary artery disease. If the CCTA is clear, you can often confidently avoid more invasive tests.
Better than traditional angiography in some ways.
Well, unlike traditional angiography, which mainly shows the shadow or outline of the blood flow channel, CCTA can actually visualize the artery wall and the plaque itself, whether it's calcified, non-calcified, or mixed. That gives us more information about the plaque characteristics.
Okay, so we've covered a lot of non-invasive and imaging tests, but what about the gold standard for diagnosis? Cardiac catheterization and angiography.
Right. Coronary angiography, performed during a cardiac catheterization procedure, is still considered the gold standard for getting a definitive roadmap of the coronary arteries.
What exactly does it define?
It precisely shows the location, length, diameter, and shape of the major coronary arteries. It reveals the presence and severity of any narrowings or blockages, the nature of the obstruction, any collateral blood flow pathways that might have developed, and even gives a sense of the speed of blood flow.
And how is the disease classified based on this?
We use classification systems, like CAS or BRI, to describe the extent of disease, typically as one vessel, two vessel, three vessel, or left main disease. A significant blockage, or stenosis, is generally defined as a 70% or greater reduction in the luminal diameter. For the critical left main artery, though, a 50% narrowing is considered significant.
But even this gold standard has limitations, right?
Yes, it does. One issue is inter-observer variability. Different doctors might interpret the severity of a blockage slightly differently. More importantly, standard angiography provides excellent anatomical information where the blockages are and how tight they look, but it doesn't always reliably tell us the functional significance of that blockage.
Meaning how much it's actually restricting blood flow.
Exactly. Sometimes a blockage that looks quite severe on the angiogram isn't actually causing a major drop in blood flow, while a blockage that looks less severe might be physiologically very significant.
So how do you assess that functional significance?
That's where we sometimes use additional techniques during the catheterization. One is fractional flow reserve, or FFR. This involves passing a special pressure-sensing wire across the blockage. We then give a medication to maximally dilate the blood vessels and measure the pressure difference across the stenosis. An FFR value below a certain threshold, usually around 0.80, indicates that the blockage is indeed causing ischemia, a significant lack of blood flow.
What about IVUS?
Intravascular ultrasonography, or IVUS, is another tool. It uses a tiny ultrasound probe on the tip of a wire that's inserted into the coronary artery. It gives us detailed cross-sectional images from inside the artery, showing the plaque burden, the composition of the plaque, and the true size of the vessel lumen. It's particularly useful for assessing borderline blockages, especially in the left main artery.
And you mentioned hybrid imaging earlier. Sounds like combining the best of different tests.
That's the idea. Hybrid imaging aims to merge the strengths of two different modalities. For example, combining PET scans, which show blood flow and metabolism, with CT scans that show anatomy. Or using CCTA data to computationally estimate FFR.
So you get both anatomical and physiological info.
Precisely. You can potentially get a fused image showing both the blockage and its impact on blood flow. While the evidence base is still growing, it holds promise for a more comprehensive, non-invasive diagnostic approach, though it can sometimes mean a higher radiation dose. This whole diagnostic toolkit is really quite impressive, isn't it? It offers so many different angles to look at a patient's condition, but as you can probably guess, deciding when to actually step in and intervene, and how to intervene, well, that's often the most complex puzzle of all. It's not just about what we can do, but figuring out what's truly best for that individual patient.
That really is the million-dollar question. Knowing you have the disease is one thing, but figuring out the best path forward, That's another challenge entirely. What do the major guidelines, like those from the American College of Cardiology and the American Heart Association, say about who needs revascularization?
The guidelines are pretty clear and are based on decades of accumulated evidence. They state that the only Class INA indication for PCI, that's percutaneous coronary intervention, so stenting or balloon angioplasty, is for an acute, severe heart attack known as a STEMI. In that situation, immediate intervention is absolutely critical.
Okay, STEMI gets PCI. What about other situations?
For almost all other indications, CABG or bypass surgery generally holds a superior class of recommendation based on the existing evidence. And it's remarkable, much of this evidence spans 4 decades, originating from landmark studies conducted way back in the 1970s and 1980s.
So CABG has this long established track record of effectiveness. How did those early trials shape our understanding of CABG versus just taking medication?
Yeah, the debate between CABG and medical therapy is really foundational. Back in the 70s and 80s, there were 3 major randomized controlled trials: the Veterans Affairs Cooperative Study, the European Coronary Surgery Study, and CAS. These studies definitively established that CABG offered a clear survival benefit over medical therapy alone for certain patients with stable ischemic heart disease.
Which patients specifically?
Particularly those with significant blockage in the left main coronary artery, or those with blockages in all 3 major coronary arteries, so-called 3-vessel disease. These studies also confirmed that CABG was much better at relieving anginal symptoms compared to just medication back then.
But medical therapy, pills for cholesterol, blood pressure, it's advanced so much since the 70s and 80s. Does that original survival benefit for CABG still hold up against modern medicine?
That's a really valid and frequently debated question. And yes, both surgical techniques and medical therapies have improved dramatically.
Right.
But even more modern studies, like the MASS-2 trial, have replicated these basic findings.
What did MASS-2 show?
It showed that even compared to contemporary medical therapy, CABG patients who had multi-vessel disease experienced lower rates of subsequent heart attacks, fewer needs for additional procedures, and lower cardiac death rates over a 10-year period compared to those getting medical therapy alone. So the argument really is that combining modern guideline-directed medical therapy, or GDMT, after CABG might actually further enhance the outcomes, potentially maintaining CABG's survival advantage, especially in complex cases.
Okay, so CABG versus meds, CABG often wins for complex disease. How about PCI, the less invasive stent option versus just medical therapy? Has stenting shown a clear survival advantage over just taking pills?
That's another really interesting point. Despite huge advancements in stent technology, especially drug-eluting stents, which dramatically reduce the chance of the artery re-narrowing inside the stent.
Right, restenosis.
Exactly. Despite that, large meta-analyses looking at data over 30 years have generally not shown that PCI reduces the risk of death or heart attack in patients who are not actively having an acute coronary syndrome.
So for stable patients?
For stable patients, yes. PCI is excellent at relieving angina symptoms and improving quality of life. It definitely does that well. But it doesn't consistently lower the long-term risk of death or future heart attacks in that stable population compared to optimal medical therapy alone.
Okay, so if PCI isn't consistently improving survival over meds in stable patients, what's the picture when you compare CABG directly to PCI, especially thinking back to the era before drug-eluting stents?
Right. Looking at the randomized trials that compared CABG to PCI using either just balloon angioplasty or the older bare metal stents, several key conclusions emerged.
What were they?
Survival rates at 1 and 5 years were generally similar between the 2 approaches, whether it was for single-vessel disease like the LAD or multi-vessel disease. The incidence of heart attacks over 5 years was also similar.
Any downsides to CABG in those comparisons?
Procedural stroke occurred slightly more often with CABG, maybe around 1.2% versus 0.6% for PCI.
But were there advantages for CABG?
Yes, 2 major ones. First, CABG was significantly more effective at providing durable relief from angina symptoms at both 1 and 5 years. Second, and this was a really striking difference, the need for repeated coronary revascularization needing another procedure down the line was performed significantly less often after CABG.
How much less of it?
We're talking maybe 4% needing a repeat procedure at 1 year after CABG versus over 26% after PCI. And at 5 years, it was about 10% for CABG versus over 46% for PCI. The difference was huge, especially compared to just balloon angioplasty.
Wow, that's a massive difference in needing repeat procedures. Now let's fast forward to the modern era. The Syntax trial really put the newer drug-eluting stents, DES, head-to-head with CABG in complex disease. What were the big takeaways from that crucial study?
Syntax was a really important large trial. It randomized 1,800 patients who had either three-vessel disease or left main disease, so complex cases to get either DES implantation or CABG surgery.
And the main outcome?
They looked at major adverse cardiac events, or M, which is a combined endpoint of death, stroke, heart attack, or needing a repeat revascularization procedure. At 3 years, MAIN occurred significantly less frequently in the CABG patients compared to the DES patients.
Okay. Were death and stroke rates different?
Death and stroke rates were actually similar between the two groups. However, the rate of heart attack was significantly higher with DES, and the rate of needing repeat revascularization was almost double with DES compared to CABG.
And didn't the complexity of the disease measured by the Syntax score play a big role in those results?
Yes, absolutely. The Syntax score is a tool used to grade the anatomical complexity of a patient's coronary artery disease. Low scores mean less complex, high scores mean very complex disease.
Right.
The trial found that the risk of MAIN correlated strongly with the Syntax score for patients getting DES, but not so much for CABG patients. For patients with low Syntax scores, less complex disease, outcomes were pretty similar between DES and CABG at 12 months.
But for more complex cases?
For patients with intermediate or high Syntax scores, meaning more complex and widespread disease, MACE occurred significantly more often after DES. And specifically for three-vessel disease, mortality at 3 years was notably higher in the PCI group compared to the CABG group.
So the conclusion from Syntax was?
The main conclusion, which was reinforced by the 5-year follow-up data, is that while outcomes might be comparable for relatively uncomplicated CAD, low Syntax score, CAB appears to be preferable and offers superior long-term results for patients with complex and diffuse coronary artery disease.
So it really underscores that it's not a one-size-fits-all decision. It depends heavily on the patient's specific anatomy and disease complexity. Let's dig into some of those specific clinical scenarios now, starting with left main coronary artery disease. You said earlier this is particularly serious.
It is. The left main artery is like the main trunk road supplying blood to maybe 2/3 of the heart muscle. A blockage here is critical. For these patients, CABG provides a clear survival benefit compared to medical therapy alone, a benefit that's been shown to extend out to 10 years or more.
Okay. And how does PCI stack up against TABG specifically for left main disease? This has been a big area of debate, hasn't it?
It has been a very hot topic, yeah. About 4% of patients undergoing angiography have significant left main disease, and most of them also have blockages elsewhere. Several large randomized trials, Syntax, Noble, Excel, Pre-Combat, have directly compared PCI with DES versus CABG for left main disease.
What have they found?
The results have been somewhat mixed, leading to some controversy, but generally they suggest that for carefully selected patients, often those with less complex left main disease, like blockages just at the opening or in the main shaft, rather than complex bifurcations, major clinical outcomes like death or stroke can be similar between PCI and CABG, at least in the first few years. But the consistent finding across almost all these trials is a significantly higher rate of needing repeat revascularization procedures after PCI compared to CABG. For instance, the Noble trial's 5-year results showed that overall MESI was significantly lower with CABG, primarily driven by fewer repeat procedures and fewer non-procedural heart attacks with surgery. All-cause mortality was similar, though.
So even with the best modern stents, CABG still seems to hold an edge for left main disease, particularly regarding durability.
Yes, CAG remains the established gold standard for left main disease, especially for patients with more complex anatomy or additional multivessel disease. PCI is considered a reasonable alternative for certain carefully selected patients, particularly those who might be poor surgical candidates or have less complex blockages amenable to stenting. Lesion location is key for PCI success here.
Right.
For complex left main disease, especially with a high Syntax score, PCI has been associated with higher long-term mortality rates compared to CABG in some analyses. This is exactly why a heart team approach is so strongly recommended.
The heart team?
Yeah, having both an interventional cardiologist and a cardiac surgeon review the case together, discuss all the factors, the anatomy, the patient's other health issues, their preferences, their ability to take blood thinners long-term to make the best joint recommendation. For acute emergencies, though, like a heart attack involving the left main, immediate PCI might be the fastest life-saving option if it can be done quickly.
Makes sense. What about disease just in the proximal LAD artery, that widowmaker vessel? How do PCI and CABG compare there?
For proximal LAD disease, CABG definitely offers a survival advantage over just medical therapy. Interestingly, when comparing PCI directly to CABG, just for isolated proximal LE disease, studies have generally shown similar survival rates between the two approaches. So that specific location is perhaps a bit different from complex multivessel or left main disease.
You often hear the term completeness of revascularization. How important is it to bypass or stent all the significant blockages?
It's considered very important, especially for long-term outcomes. The goal of any revascularization procedure is to restore adequate blood flow to all areas of the heart muscle that are ischemic or starved for blood.
And CABG usually achieves that.
Yes, most patients undergoing CABG achieve complete or near complete revascularization, meaning all significant blockages are bypassed. This has been consistently linked to better long-term prognosis, including improved survival and freedom from angina.
How does PCI compare in that regard?
PCI, while effective, achieves complete revascularization less often, maybe around 70% of the time in multivessel disease cases. The impact of incomplete revascularization after PCI on long-term outcomes is a bit less clear than with CABG, but generally, achieving complete revascularization is considered the ideal goal for both procedures whenever feasible and safe.
Okay. What about the challenging group of patients who have coronary artery disease and left ventricular systolic dysfunction, meaning a weakened heart pump?
That's a really important group. For patients with a weakened heart muscle, older studies and meta-analyses consistently reported better survival with CABG compared to medical therapy alone, particularly for those with mild to moderate dysfunction.
What about more severe heart failure?
The STCH trial was a landmark study specifically looking at patients with severe heart failure due to blockages and ejection fraction less than 5%. Initially, the 5-year results showed similar survival rates between patients getting CABG plus optimal medical therapy GDMT and those getting GDMT alone.
Oh, interesting. So CABG didn't help initially.
Well, that was the 5-year finding for all-cause mortality. However, the crucial 10-year follow-up data from STCH painted a different picture. At 10 years, rates of death from any cause, death from cardiovascular causes, and death or hospitalization for cardiovascular causes were all significantly lower in the group that received CABG plus medical therapy.
So a definite long-term benefit emerged for CABG in severe heart failure.
Yeah.
What about PCI in this group?
There's actually limited high-quality randomized trial data, specifically comparing PCI to medical therapy or CABG in patients with severe LV dysfunction. The evidence base for CABG in this population is much more robust, so the decision-making for these patients is highly individualized based on clinical judgment, the patient's overall condition, the coronary anatomy, and consultation between specialists, again, that heart team approach.
What about patients who've already had a CABG years ago and now have recurrent symptoms? Do they get PCI or another CABG?
That's a very common scenario. As we mentioned, symptoms can recur in 15% within 5 years, maybe 40% by 10 years. This is usually due to progression of disease in their native arteries or, unfortunately, disease developing in the bypass grafts themselves, especially vein grafts.
So what are the options?
The general indications for reintervention, whether it's PCI or a repeat CABG, reduced CABG, are pretty much the same as for the first time around. These patients are typically older, often have more diffuse and complex disease, and might have diminished heart function.
Is reduced CABG riskier?
Yes, reduced CABG is generally considered a higher risk than a first-time operation due to scar tissue and the technical challenges of re-entering the chest.
So how do they choose between PCI and reduced CABG?
Cohort studies suggest that midterm and long-term survival rates can be similar between the two approaches. The decision depends heavily on individual factors. Factors favoring reduced CABG might include having multiple diseased bypass grafts, especially if the Lima graft is still good and can be reused, or if there are good native artery targets distal to the blockages. Factors favoring PCI might include having only limited ischemia, suitable blockages for stenting, especially in old vein grafts, a patent Lima graft supplying the LAD, poor targets for surgery, or significant other health problems that make redo surgery too risky.
Okay. What about patients presenting with acute coronary syndromes that aren't full STEMI heart attacks, like unstable angina or NSTEMI? Is the approach different?
For unstable angina, or NSTEMI, there's generally a stronger and more urgent impetus for revascularization compared to stable disease. The heart muscle is actively ischemic and potentially at risk of significant damage. Revascularization is much more likely to reduce angina symptoms than just medical therapy alone in these acute settings.
And the choice between PCI and CBG?
The choice of how to revascularize PCI versus CABG generally follows similar considerations as for stable disease, weighing the anatomy, complexity, patient factors, etc. But the decision is often made more quickly due to the acute nature of the problem.
Finally, let's talk about the most acute situation. ST segment elevation myocardial infarction, or STEMI, a full-blown heart attack. How does revascularization fit into that emergency?
In STEMI, time is muscle. The goal is to restore blood flow to the blocked artery as quickly as possible. Immediate primary PCI, taking the patient straight to the cath lab for ballooning and stenting, is generally considered superior to using thrombolytic drugs, the clot busters, especially if PCI can be performed rapidly.
How rapid is rapid?
The key metric is door-to-balloon time, the time from when the patient arrives at the hospital to when the blocked artery is opened. PCI-capable hospitals aim for this to be 90 minutes or less. Achieving faster times is directly linked to better survival. If PCI cannot be performed within that time frame, then thrombolytic therapy is the alternative, with a goal door-to-needle time of 30 minutes or less.
What's the role of CABG in acute STEMI? Has that changed?
Yes, the role of emergency CABG during an acute STEMI has diminished significantly with the success and availability of rapid primary PCI. Patients who undergo CABG very early after a STEMI are typically much sicker, often have complex multivessel disease not suitable for PCI, may already be in shock, or require mechanical support like an intra-aortic balloon pump.
Is there an optimal timing if CABG is needed after a STEMI?
The optimal timing isn't perfectly established, but studies suggest that if CABG is needed, but the situation isn't immediately life-threatening, deferring the surgery for at least 3 days after the heart attack might improve outcomes compared to operating on day 0 or day 1.
What about cardiogenic shock, complicating a STEMI?
For patients who develop cardiogenic shock where the heart is failing as a pump due to the large heart attack, the landmark SHOCK trial showed a clear survival advantage for emergency revascularization, either PCI or CABG, compared to initial medical stabilization alone. Even though CABG patients in that trial tended to have worse underlying disease, their survival rates were similar to the PCI group.
And CABG is also used for the mechanical complications.
Yes, emergency CABG is often performed concurrently when surgery is needed for those devastating mechanical complications of a heart attack we discussed earlier, like repairing a hole in the heart, VSD, or replacing a valve due to papillary muscle rupture. The high risk of death from these mechanical problems drives the need for urgent surgical repair, which usually includes bypassing any other significant blockages at the same time.
So, wrapping up this section on indications, what's the big picture? It seems clear that choosing between CABG and PCI isn't straightforward at all.
Absolutely not. These guidelines and the wealth of clinical trial data paint a really complex picture. They highlight that the decision is rarely simple or black and white. It's a highly personalized choice that requires careful consideration of the patient's specific coronary anatomy, the extent and complexity of their disease, like the syntax score, their other medical conditions, their age and frailty, and importantly, their own preferences and values. It truly necessitates that heart team approach we talked about.
Definitely sounds like a team effort. So let's say the decision is made for CABG, specifically the conventional on-pump approach. What actually happens in the operating room? Walk us through that.
Okay, the conventional on-pump CABG is it's a sophisticated and highly choreographed procedure. It really starts well before the operating room, with that meticulous preoperative evaluation we discussed.
Right, the workup.
Success really hinges on proper preparation and careful patient selection. That often involves the multidisciplinary heart team cardiologists, surgeons weighing all the factors, age, other conditions like diabetes or kidney disease, the urgency, the heart's pumping strength, ejection fraction, and of course the detailed roadmap from the cardiac catheterization.
And the essential tests beforehand.
It's comprehensive. Detailed history and physical, including checking the legs or arms for suitable blood vessels to use as bypass grafts. Reviewing all medications, especially blood thinners, often an ultrasound of the carotid arteries if there's stroke risk. A detailed cardiac ultrasound, echocardiogram, is crucial, and the cath report, of course. Plus, standard blood work counts, kidney function, clotting tests. In emergencies, some steps might be compressed, but the core information is gathered.
Okay, so the patient's ready, they're in the OR. What are the major steps of the conventional on-pump procedure?
It typically follows a fairly standard sequence, although there can be variations. First, anesthesia is induced, and all the monitoring lines, arterial lines, central lines, etc. are placed.
Getting set up.
Exactly. The patient is positioned, usually flat on their back, and prepped sterilely from neck to ankle, basically, to allow access to the chest and potential graft harvest sites like the legs or arms.
Then the incision.
Then the surgeon performs a median sternotomy, that vertical incision opening the breastbone to get access to the heart. While that's happening or just after, another part of the team might be harvesting the conduits, the blood vessels to be used for the bypasses, like the internal mammary artery from the chest wall or saphenous veins from the legs.
Okay, conduits harvested. What's next?
The patient is given a large dose of heparin, the blood thinner. Then cannulas or tubes are inserted into the large vessels, usually the aorta for arterial blood return and the right atrium for venous blood drainage, connecting the patient to the cardiopulmonary bypass machine, the heart-lung machine.
Going on bypass.
Right. Once bypass is fully established and the machine is supporting the circulation, the surgeon applies a cross-clamp to the aorta, isolating the heart. Then, cardioplegia solution is delivered to safely stop the heart and protect the muscle.
Art stopped, surgeon works.
Exactly. With the heart still unprotected, the surgeon meticulously identifies the blocked coronary arteries on the surface and performs the distal anastomosis, sewing the bypass grafts to the coronary arteries beyond the blockages.
Delicate work.
Extremely. Once all the distal connections are done, the cross clamp is removed, allowing blood flow back to the heart muscle.
No.
The heart usually starts beating again on its own or may need a small electrical shock. Then the proximal anastomoses are done, connecting the other end of the grafts, usually the vein grafts, to the aorta.
Then coming off bypass.
Yes. Once the heart is beating strongly and the patient is rewarmed, they are gradually weaned off the cardiopulmonary bypass machine. The cannulas are removed. Bleeding is meticulously controlled. The heparin is reversed with protamine. Chest tubes are placed for drainage. And finally, the sternum and incision are closed.
Let's talk a bit more about that heart-lung machine, cardiopulmonary bypass, or CPB. It sounds like an engineering marvel. How does it work?
It really is foundational to most complex cardiac surgery. CPB essentially creates an artificial circulatory and respiratory system outside the body. It works by diverting all the venous blood returning to the heart before it gets there, into the machine.
Yeah, and in the machine.
In the machine, the blood passes through an oxygenator, which acts like an artificial lung, adding oxygen and removing carbon dioxide. It also goes through a heat exchanger to control the patient's body temperature, often cooling them down initially. Then a pump pushes the oxygenated blood back into the patient's arterial system, usually via the aorta, effectively bypassing the heart and lungs altogether.
Allowing the surgeon complete control.
Exactly. It provides a still, bloodless field, which is absolutely essential for the precision needed to sew those tiny grafts onto coronary arteries that might only be a millimeter or two wide. The machine has various components: the cannulas, reservoirs, the oxygenator, heat exchanger, pumps, filters, all designed to handle blood gently.
How was it initiated and managed during the surgery?
Before connecting to the patient, the entire circuit is primed with a sterile, non-blood fluid. There are also auxiliary systems. One is the cardiotomy suction, which collects any blood spilled in the surgical field, filters it, and returns it to the main circuit. Another separate device delivers the cardioplegia solution to stop and protect the heart.
And anticoagulation is key.
Absolutely critical. Because the blood is contacting foreign surfaces in the bypass circuit, which strongly stimulates clotting, the patient must be fully anticoagulated with heparin. We use a test called the activated clotting time, or ACT, and maintain it at a very high level, usually over 450 seconds, throughout the time on bypass.
What about protecting the brain during this whole process? That seems like a major concern.
Neurologic protection during CPB is paramount. While the risk of a major stroke is relatively low, around 1.5%, more subtle neurocognitive changes can be more frequent. Several strategies are used to minimize these risks.
Such as?
Maintaining adequate blood pressure and flow to the brain is key. Minimizing the release of tiny particles, microemboli, like fat or air bubbles, into the circulation is crucial. This often involves limiting the use of cardiotomy suction and careful handling of the aorta.
Does cooling help?
Yes. Moderate hypothermia, cooling the patient's body temperature down, often into the low 30s or even high 20s Celsius, significantly reduces the body's overall oxygen consumption. This makes the brain and other organs more tolerant of the slightly lower flow sometimes used during bypass. However, cooling also means longer rewarming times at the end, and it can affect platelet function and increase bleeding risk, so it's a balance.
Okay. And the median sternotomy, that classic chest incision. What are the key things to know about that?
The median sternotomy is still the standard approach for most CABG procedures. It involves making an incision down the front of the chest and carefully dividing the sternum, the breastbone, right down the middle using a specialized saw.
Precision is important.
Very. The surgeon needs to stay exactly in the midline to ensure proper healing and stability afterwards. Care is taken to avoid injuring the lungs or the heart, and major vessels lying directly underneath. Once the sternum is divided, bleeding from the bone edges is controlled, often using bone wax or electric cautery.
Now, let's get back to the conduits, the new arteries or veins used for the bypasses. You mentioned the lima as the gold standard. Why?
The left internal mammary artery, or lima, also called the left internal thoracic artery, is really the star player. Seminal studies, particularly from the Cleveland Clinic group led by Loop, published decades ago, showed dramatically improved long-term survival in patients who received a lima graft compared to those who only got saphenous vein grafts.
How much better?
The risk of death was something like 1.6 times higher if you only got vein grafts. And the lima graft itself has phenomenal long-term patency rates, meaning it stays open. We're talking around 95% open at 10 years and still around 90% open at 20 years. Its best performance is when it's used in situ, left attached to its origin under the collarbone, and sewn down to the LAD artery.
So if one mammary artery is so good, using both of them bilateral internal mammary artery grafting, or BIMA, it sounds like it should be even better, right? Is that common practice?
That's the logical thought, and conceptually, using both IMAs aims for total arterial revascularization, which should theoretically be more durable than using vein grafts. Many observational studies have suggested that BIMA grafting does improve long-term survival and reduces the need for reoperation without significantly increasing the operative mortality.
But
the randomized trial evidence has been less definitive. The large ART trial, for instance, showed a higher rate of deep sternal wound infections with BIMA, especially in higher-risk patients like diabetics or the obese, although this risk might be reduced by using a skeletonized harvesting technique where only the artery itself is taken with less surrounding tissue. And importantly, the 5-year and 10-year follow-ups of ART did not show a significant difference in mortality or major cardiovascular events compared to using a single IM plus other grafts.
so who gets BIMA then?
It's often reserved for younger, lower-risk patients, where the potential long-term benefit might outweigh the slightly increased upfront risks. It requires experienced surgeons, and careful patient selection is key.
Okay. And the classic saphenous vein graft taken from the leg, how does that compare durability-wise?
The greater saphenous vein, or SVG, is still the most commonly used conduit after the lima. It's readily available and relatively easy to harvest. Its patency rate is actually quite good, initially maybe 90% at 1 year.
But long-term?
That's where the difference lies. Beyond about 5 years, vein grafts are susceptible to developing atherosclerosis themselves, a process called graft atherosclerosis. As a result, by 10 years, only about 60–70% might still be open, and maybe half of those show some signs of disease on an angiogram. So definitely less durable long-term than the lima.
How are vein grafts typically harvested?
Traditionally, it was done via a long incision down the leg, which could lead to wound complications, pain, and slow healing, especially in diabetics or those with poor circulation. Nowadays, less invasive techniques are common, like endoscopic vein harvesting, EVH, where the vein is removed through small keyhole incisions using a camera. A recent large trial called Regroup demonstrated that EVH is safe and effective, providing comparable graft patency to open harvesting, but with fewer leg wound complications.
Okay, so a typical bypass might be lima to the LAD and vein grafts elsewhere.
Exactly. That's a very standard configuration for a 3-vessel bypass, for example. The lima goes to the most critical vessel, the LAD, and then aortocoronary bypasses are created using sections of reverse saphenous vein going to targets like the distal RCA or branches of the circumflex artery.
What if those standard conduits aren't available or suitable? Say, someone's had previous vein stripping, or their veins are varicose, or they've had previous bypass surgery. Are there other alternatives?
Yes, absolutely. This comes up frequently. Alternative conduits or strategies are needed in those situations, or for patients with severely calcified ascending aortas where sewing grafts directly onto the aorta is risky.
What are the options?
Other arterial conduits can be used. The radial artery from the forearm is a common second choice. It's relatively easy to harvest and can reach most coronary territories. Studies have shown it has better patency than vein grafts at 5 years.
Any downsides to the radial artery?
Yes, it's more prone to spasm, which needs careful management with medications. It also seems to work best and stay open longest when it's grafted onto a very severely blocked native coronary artery, ideally 90% stenosis or more. If the native vessel isn't tight enough, there can be competitive flow, which can lead to the radial graft narrowing down over time, the string sign. No study has definitively shown a survival advantage over using SVGs.
Any other arteries used?
The right gastroepiphloric artery, which runs along the stomach, is another option, though it's used much less commonly today, particularly in Western countries. Evidence suggests vein grafts might actually have better patency for bypassing the RCA territory.
So this idea of total arterial revascularization, using only arteries like lima, rima, and radial, is that becoming standard?
It's a goal for many surgeons, aiming to avoid the long-term limitations of vein grafts. Over 90% of bypass operations in many Western countries still use the standard lima plus vein graft approach. While retrospective studies suggest some survival benefit with total arterial revascularization, there are pragmatic reasons why it hasn't been universally adopted.
Such as?
Concerns about arterial graft spasm, the need for very tight target vessel blockages, sometimes inadequate length of grafts to reach all targets, the increased risk of sternal wound problems with BEMA grafts, especially in high-risk patients, and generally longer operative times. So many surgeons reserve total arterial revascularization primarily for younger patients who have a longer life expectancy and lower surgical risk.
Got it. Once the conduits are chosen and harvested, how do they actually connect the patient to the cardiopulmonary bypass machine? What's involved in cannulation?
Cannulation is the process of inserting the tubes, or cannulas, into the patient's major blood vessels to hook them up to the heart-lung machine. This happens after the chest is open, the conduits are ready, and the patient is fully heparinized.
Where do the cannulas go?
The arterial cannula, which returns the oxygenated blood from the pump to the patient, is typically placed in the ascending aorta, the large artery leaving the heart. The surgeon carefully chooses a spot that's free of calcium or plaque to minimize the risk of dislodging debris that could cause a stroke. Sometimes, if the aorta is heavily diseased, alternative sites like the femoral artery in the leg or the axillary artery under the collarbone are used.
And for draining blood out?
For venous drainage, 1 or 2 large cannulas are inserted into the right atrium, often through the appendage, to collect all the venous blood returning to the heart and divert it by gravity into the bypass machine's reservoir.
Okay, connected to bypass, then the heart needs to be stopped safely. How is that achieved, and how is the heart muscle protected during this time?
Right. Once CPB is fully established and supporting the circulation, the heart needs to be arrested to allow the surgeon to work precisely. This is done by applying a cross clamp across the ascending aorta, proximal to the arterial cannula, which isolates the heart from the systemic circulation.
And then the cardioplegia.
Exactly. A cold high potassium solution called cardioplegia is then infused directly into the coronary circulation, usually through a needle placed in the aorta between the clamp and the aortic valve, antegrade delivery. This solution quickly stops the heart in diastole, the relaxed state, and the cold temperature dramatically reduces its metabolic needs, protecting the muscle cells from damage during the time it's not receiving blood flow.
This is delivered just one way.
Often, a balanced approach is used. Cardioplegia can also be delivered retrograde, meaning backwards through the coronary sinus, which is the main vein draining the heart muscle. A special catheter is placed into the coronary sinus via the right atrium. This retrograde delivery helps ensure the protective solution reaches areas downstream from very tight blockages that antegrade flow might not reach effectively. Sometimes both methods are used and additional doses are given periodically, maybe every 15-20 minutes, throughout the time the aorta is clamped.
And the goal is complete protection.
Yes, the most important task is achieving a complete, quiet diastolic arrest with the heart decompressed or unloaded. This minimizes the heart's energy consumption, preserving the muscle cells. The combination of CPB taking over the pumping work, unloading the ventricle, systemic cooling, topical cooling with ice slush sometimes, and the cardioplegic arrest itself all work together to drastically decrease the heart's oxygen demand during the operation.
Now for the really intricate part.
Yeah.
Identifying the target vessels on the stopped heart and sewing on the new bypass grafts.
Yes. Once diastolic arrest is achieved and the heart is still, the surgeon meticulously identifies the target coronary arteries. These are often small vessels, maybe 1 to 2 millimeters in diameter, sometimes running under fat or even within the heart muscle itself, so experience is key to finding the right spot.
How is the connection made?
The target vessel is carefully opened with a tiny, precise incision, usually a longitudinal arteriotomy about 5 millimeters long, using a very sharp blade. Then the prepared end of the bypass conduit, which has been cut and shaped appropriately, is sewn to the opening in the coronary artery in an end-to-side fashion. This is done using extremely fine sutures, typically 7/0 or 8/0 prolene, which is thinner than a human hair. This is arguably the most technically demanding part of the operation, requiring immense precision and skill.
And they test the connection.
Yes, the flow and integrity of each graft, especially vein grafts, are often tested by gently flushing them with cold blood or cardioplegia solution before completing the other end.
Is the lima-lad connection different?
That anastomosis, connecting the lima to the LAD, is often performed last among the distal connections. This is because once it's done, you want to minimize manipulation of the heart to avoid accidentally pulling on or damaging that critical graft. For targets on the back or underside of the heart, like the PDA or obtuse marginal branches, the surgeon needs to gently lift and rotate the heart to get adequate exposure.
Can one graft supply more than one vessel?
Yes, sometimes a technique called sequential anastomosis is used. A single conduit, like a vein graft or even the lima, can be used to supply blood to two different target vessels. It's sewn side to side to the first target and then end to side to the second, more distal target. This can be useful when conduits are limited or if the target vessels are very small, as it ensures higher flow through the graft, potentially reducing risk of clotting.
Once all the distal connections are done, how do they connect the other ends and get the heart beating again and come off the bypass machine?
Right. As the last distal anastomosis is being completed, the process of rewarming the patient back to a normal physiologic temperature begins. Once all discal grafts are done, a final dose of cardioplegia, sometimes a warm hot shot, might be given to help the heart wake up and scavenge any metabolic byproducts. Then the aortic cross-clamp is removed.
Allowing blood back into the coronary.
Exactly. The heart usually starts to beat spontaneously fairly quickly, or it might require defibrillation with paddles. Then the proximal anastomoses are constructed. For vein grafts or free arterial grafts, this involves sewing the other end of the conduit onto the ascending aorta. A partial occlusion clamp is often used on the aorta to allow these connections to be made while blood is still flowing through the aorta to the rest of the body. If the aorta is very diseased or calcified, sometimes these proximal connections are made while the cross clamp is still on, using a single clamp technique to minimize aortic manipulation.
Then coming off bypass.
Yes, separating from cardiopulmonary bypass is a critical phase. It begins once the heart has resumed a good regular rhythm. The patient's core temperature is back above 36.5 degrees C, and the team is confident there's adequate blood volume available. Temporary pacing wires are usually placed on the heart surface just in case electrical support is needed.
How is the transition managed?
The perfusionist gradually decreases the flow from the bypass machine, while the surgeon and anesthesiologist closely monitor the heart's function visually via the hemodynamic monitoring lines, like a Swan-Ganz catheter measuring pressures inside the heart, and often with transesophageal echocardiography, TEE.
What kind of support might be needed?
As the heart takes over its workload again, patients often experience a temporary systemic inflammatory response from the bypass, causing vasodilation. They might need extra fluids or vasopressor medications to maintain blood pressure. If the heart's pumping function is sluggish, inotropic agents might be used temporarily to boost contractility. It's a dynamic process requiring excellent teamwork and communication to ensure a smooth transition back to the patient's own circulation.
And controlling bleeding after all this, especially after heparinization, must be a major focus.
Hemostasis, stopping the bleeding, is absolutely critical. After the patient is successfully weaned from CPB and the cannulas are removed, the heparin anticoagulation is reversed with protamine sulfate. During and after protamine administration, the surgical team meticulously inspects all surgical sites, the conduit harvest sites, the sternotomy, the anastomosis sites for any bleeding.
What causes bleeding?
As the patient fully rewarms, vessels that might have constricted can dilate and start bleeding again. Persistent bleeding can indicate a surgical issue needing repair, residual heparin effect, platelet dysfunction caused by the bypass machine, or hypothermia. Close monitoring of chest tube drainage and coagulation tests guides the administration of blood products like platelets, plasma, or cryoprecipitate if needed. Meticulous surgical technique throughout the operation is the best prevention.
Finally, closing the chest.
Once hemostasis is satisfactory, chest tubes are placed in the mediastinum and sometimes the pleural spaces to drain any residual blood or fluid. The temporary pacing wires are secured. Then, the sternum is carefully reapproximated, usually with strong stainless steel wires passed around or through the bone. Finally, the overlying layers of muscle, fascia, subcutaneous tissue, and skin are closed with sutures. This whole journey through a conventional CABG is just a powerful reminder of how human ingenuity and technology combine to literally mend a broken heart. It's an incredibly complex, highly choreographed procedure. But as you said, the story doesn't end in the OR. What are the tools and strategies used to support the patient during that critical, immediate recovery phase?
Exactly. The surgery itself is just one, albeit major part. What critical tools help monitor and fine-tune the heart's function right after the bypass is done and in the early hours in the ICU?
Well, transesophageal echocardiography, or TE, remains invaluable right in the operating room and immediately post-op in the ICU. That ultrasound probe in the esophagus gives real-time, high-resolution pictures of the heart.
What are they looking for specifically with TE post-bypass?
They can immediately assess how well the heart is contracting overall, look for any new wall motion abnormalities, areas that aren't squeezing well, which could suggest a problem with a newly placed bypass graft. They can also check valve function, for instance, if new mitral valve leakage has developed, and assess the heart's filling pressures and volume status. It's like having an internal window giving constant feedback.
And what about medications to support the heart and circulation? You mentioned some might be needed during weaning from bypass.
Yes, pharmacological support is often crucial in the early hours. Remember, the heart has undergone a period of arrest and reperfusion, which can cause some temporary stunning or stiffness. Plus, the systemic inflammatory response to bypass often leads to vasodilation, or leaky capillaries causing third spacing of fluid.
So what types of drugs are used?
Inotropic agents, like epinephrine or sometimes dobutamine or milrinone, might be used to boost the heart's contractility if the pump function is low. Vasopressors, such as norepinephrine, phenylephrine, or vasopressin, are often needed to counteract the vasodilation and maintain adequate blood pressure, ensuring good perfusion to the vital organs.
What about managing blood pressure? Too high is bad too, right?
Absolutely. It's a delicate balancing act. You need the mean arterial pressure high enough, usually above 60-65 millimole Hg, to perfuse the organs, especially the kidneys and brain. But you want to avoid hypertension, which puts unnecessary stress on the recovering heart and the fresh suture lines, and can increase bleeding risk. Vasodilators like nitroglycerin or sodium nitroprusside might be used if blood pressure is too high. Careful fluid management is also key. Urine output is a really reliable bedside indicator of how well the organs are being perfused.
What happens if medications and fluids aren't enough? When is mechanical support like an intra-aortic balloon pump needed?
The intra-aortic balloon pump, or IABP, is reserved for patients with significant myocardial dysfunction who aren't responding adequately to volume resuscitation and high doses of medications. If the heart is really struggling to pump effectively after surgery, an IABP can provide temporary mechanical assistance.
How does it work again?
It's a balloon catheter, usually inserted via the femoral artery in the leg and positioned in the descending aorta just below the arteries branching off to the arms and head. It's connected to a console that inflates and deflates the balloon in precise synchronization with the patient's heartbeat, timed off the ECG or arterial pressure waveform.
And the benefit?
It provides two main benefits. It inflates during diastole when the heart is relaxing, which increases pressure in the aorta and pushes more blood back into the coronary arteries, improving the heart's own oxygen supply. Then, it rapidly deflates just before systole, just before the heart contracts, which creates a momentary vacuum or reduction in pressure in the aorta. This reduces the resistance, or afterload, that the struggling left ventricle has to pump against, making it easier for the heart to eject blood and reducing its workload and oxygen consumption. Essentially, it improves the supply-demand ratio for the heart muscle.
Are there situations where it can't be used?
Yes, it's absolutely contraindicated in patients with significant aortic valve regurgitation because inflating the balloon would just push more blood back into the left ventricle. It's also contraindicated in aortic dissection. And it's used with caution in patients with severe peripheral vascular disease, as inserting the catheter can be difficult or cause complications.
These adjuncts really show how comprehensive cardiac care is, going way beyond just the surgical cuts. But what about the day-to-day recovery? What does that look like, and what are the main goals once the patient gets to the ICU?
Right. Post-operative care in the intensive care unit is a very structured and vigilant process focused on stabilization and early recovery. It starts immediately upon arrival from the OR with a thorough handover and assessment checking vital signs, hemodynamics, neurological status, and all the lines and tubes.
What's monitored constantly?
Continuous ECG monitoring is crucial to watch for any arrhythmias or signs of ischemia. The arterial line provides beat-to-beat blood pressure. Central venous pressure helps guide fluid management. Pulse oximetry tracks oxygen saturation. Core body temperature is monitored. In sicker patients, a Swan-Ganz catheter might be used to measure pressures inside the heart and cardiac output directly. And hourly monitoring of chest tube drainage is vital to detect excessive bleeding or tamponade early.
What about breathing support?
Patients typically arrive from the OR still on a ventilator. Initial settings often mimic those used in the OR, but they're quickly adjusted based on arterial blood gas results and the patient's respiratory effort. We try to avoid excessively high ventilator pressures, especially if the patient's hemodynamics are unstable.
And imaging and labs.
A portable chest X-ray is usually taken shortly after arrival in the ICU. It confirms the position of the endotracheal tube, central lines, chest tubes, and pacing wires. It also checks for complications like pneumothorax, significant atelectasis or lung collapse, pulmonary edema, or large pleural effusions. Initial lab work includes a complete blood count, electrolytes, kidney function tests, coagulation profile, and arterial blood gases.
What are the immediate goals in those first few hours in the ICU?
The primary goals in the first 12 hours or so are really about achieving stability. Maintaining adequate blood pressure and cardiac output is paramount. Correcting any residual coagulation defects or electrolyte abnormalities, like low potassium or magnesium, is important. Stabilizing intravascular volume with fluids or blood products as needed. And normalizing peripheral vascular resistance, often using vasoactive medications. A critical early step is also performing a thorough neurological assessment as soon as the patient begins to wake up from anesthesia to detect any signs of stroke.
And looking at the overall post-operative period in the ICU, what are the broader objectives?
Okay, the overarching goals are multifaceted. We want to avoid marked swings in blood pressure, keeping it in a safe range, typically a mean pressure between 60 and 80 millimiller Hg, ensuring good organ perfusion. Maintaining normothermia, keeping the core body temperature above 36.5 degrees C using warming blankets is important for coagulation and comfort. We aim for adequate cardiac output, often targeting a cardiac index above 2.2 limitum 2, and good oxygen delivery, reflected in mixed venous oxygen saturation above 60%. Reducing afterload, the resistance the heart pumps against, helps minimize myocardial work, especially if the heart function is impaired. Judicious volume resuscitation is key. Maintaining an adequate hemoglobin level, usually above HDL, sometimes higher in older or sicker patients, correcting metabolic acidosis, which can indicate poor perfusion, monitoring neurological and peripheral vascular status closely, maintaining a stable heart rhythm, ideally sinus rhythm, between 70-100 beats/min, and promptly treating any significant arrhythmias. Ensuring adequate pain control is vital. And keeping blood glucose levels well controlled, typically below 180 milli-GDL, often requires an insulin infusion, especially in diabetics.
What about pulmonary care specifically? Getting patients breathing on their own seems like a major milestone.
It absolutely is. Extubation, removing the breathing tube, is ideally done as soon as the patient meets criteria. They need to be awake and alert, hemodynamically stable with minimal bleeding, able to protect their airway, and capable of maintaining satisfactory spontaneous breathing, good tidal volumes, and respiratory rate with adequate oxygenation on minimal ventilator support.
And after extubation.
Aggressive pulmonary hygiene is crucial. This involves encouraging coughing and deep breathing exercises, often using an incentive spirometer, while teaching the patient proper sternal precautions like hugging a pillow when coughing to support the healing breastbone. Early mobilization is also key. If pulmonary function is suboptimal, treatments like bronchodilators or chest physiotherapy might be needed.
You mentioned pain control is vital. Why is that so important post-extubation?
Sufficient pain relief after extubation is absolutely critical. Unrelieved pain causes significant emotional distress, makes patients reluctant to cough or move, and can lead to shallow breathing. Physiologically, pain triggers the stress response, leading to tachycardia, hypertension, and increased myocardial oxygen demand, which is exactly what you want to avoid after heart surgery. Poor coughing and mobility due to pain significantly increase the risk of atelectasis, hypoxia, and pneumonia.
So when do patients typically move out of the ICU? What signifies they're ready for the regular ward?
Discharge from the ICU usually happens when the patient is hemodynamically stable off vasoactive drips, breathing comfortably without the ventilator, has minimal chest tube drainage, and doesn't require intensive minute-to-minute monitoring anymore. Before transfer, unnecessary lines and catheters, like the arterial line or central line, are usually removed. Chest tubes are typically pulled around 48 hours post-op if drainage is low, less than 200 millimillials per shift, and the test x-ray looks okay. Temporary pacing wires are often removed on the third or fourth post-operative day. Once these milestones are met, they're ready for the step-down unit or surgical ward.
Okay, that's the recovery process. Now let's talk about the bottom line, outcomes. How do we measure the success and also the challenges and risks of CABG?
Measuring success starts with looking at hospital mortality, the risk of dying during the initial hospitalization for the surgery. Several core variables have been consistently shown to have the greatest impact on this risk.
What are the big ones?
The urgency of the operation emergency surgery is riskier than elective. The patient's age, whether they've had prior heart surgery. Female gender is associated with slightly higher risk in some groups. The preoperative left ventricular ejection fraction, or how well the heart pumps, the severity of any blockage in the left main coronary artery, and the number of major coronary arteries with significant blockages, for example, 3-methyl disease. Other factors like recent heart attack, diabetes, kidney disease, or peripheral vascular disease also contribute, but those core 7 are often the most predictive.
And what are the typical rates these days?
In most modern experience centers, the operative mortality for elective or urgent CABG is quite low, generally ranging from 1% to 3%.
How are these results usually reported or compared?
The gold standard now is to report risk-adjusted outcomes. This means using statistical models like the widely used Society of Thoracic Surgeons STS risk calculator, which takes into account all those patient risk factors we just discussed, to predict an individual patient's expected risk of mortality and major complications. Hospitals and surgeons can then compare their actual results to the predicted results for their specific patient population. This allows for much fairer comparisons of quality.
Okay, that's short-term mortality. What about long-term survival after CAB? What influences how well people do years down the road?
Long-term survival is influenced by a combination of factors. Both cardiac factors and non-cardiac comorbidities play a role. Persistent traditional atherosclerosis risk factors, continued smoking, uncontrolled high cholesterol, hypertension, or diabetes definitely impact long-term outcomes negatively.
But what about the heart function itself?
The state of the left ventricular function before surgery remains a powerful predictor of late survival. CABG can improve function in some cases, but it doesn't completely negate the negative impact of pre-existing significant heart muscle damage. Also, achieving complete revascularisation, bypassing all significant blockages, is associated with better long-term survival. And crucially, the use of the Lima graft, and potentially Bema grafts in some studies, significantly improves long-term survival compared to using only vein grafts.
Do we have historical data on long-term survival?
Yes, large registries like the TAXS registry provided valuable long-term data from earlier eras of CABG. They documented overall survival rates around 90% at 5 years, 74% at 10 years, and 56% at 15 years post-surgery. However, these figures are generally considered inferior to what's achievable with modern techniques, particularly the routine use of mammary artery grafts compared to age-matched populations.
Beyond survival, what about morbidity, the complications that can happen after surgery, even if the patient survives?
Right. Morbidity is also a critical outcome measure. One serious early complication is cardiac tamponade.
What is that exactly?
It's when blood or clot accumulates in the pericardial sac around the heart, compressing the heart chambers and preventing them from filling and pumping properly. It usually presents as low cardiac output, low blood pressure with a fast heart rate, and distended neck veins, elevated central venous pressure. An abrupt decrease or cessation of chest tube drainage can paradoxically be a key sign that a clot is forming and blocking the tubes. Diagnosis is confirmed by echocardiography showing fluid around the heart. It requires urgent return to the OR for evacuation of the clot.
What about postoperative bleeding requiring intervention?
Significant postoperative bleeding is another major concern. It's increased by the effects of heparin, hypothermia, the bypass pump itself damaging platelets, and sometimes inadequate reversal with protamine. Excessive bleeding might necessitate large volume blood transfusions or even reoperation to find and control the source, both of which increase morbidity and mortality. Certain patients are at higher risk. Box 60.5 outlines these, including elderly, anemic, those on antiplatelets, reoperations, emergency cases, kidney failure. Blood conservation strategies are important in these patients. About 2-3% of patients might require re-exploration in the OR for bleeding, usually defined as excessive chest tube output.
Neurologic complications are always a worry too, right? Stroke or cognitive changes.
Yes. Neurologic complications are broadly categorized as type I, major events like stroke with a focal deficit, and type 2, more generalized issues like confusion, delirium, or memory problems. Older studies reported rates around 6%, with type I events carrying higher mortality. Consistent risk factors include older age, especially 70, pre-existing hypertension or neurologic problems, diabetes, and significant atherosclerosis in the aorta, particularly the ascending aorta. Careful surgical technique to minimize manipulation of the aorta and embolization is key. If a patient has significant carotid artery stenosis, that might be addressed before or concurrently with the CABG to reduce stroke risk.
What about infections, particularly deep sternal wound infections?
Mediastinitis, or deep sternal wound infection involving the bone and space behind it, is a dreaded complication, although thankfully rare, with an incidence of 1–2%. Major risk factors include obesity, diabetes, especially poorly controlled blood sugar, reoperation, prolonged or complex surgery, and sometimes the use of bilateral mammary artery grafts in high-risk individuals. Prevention is key. Strict sterile technique, perioperative antibiotics, and rigorous blood glucose control, keeping levels below 180 mg/dL with IV insulin protocols, are standard practice. Treatment requires aggressive surgical debridement and often complex wound closure techniques like muscle flaps or vacuum-assisted closure devices.
And kidney problems.
Acute kidney injury or renal dysfunction is unfortunately not uncommon after CABG, with reported incidences around 7–8%. Even mild dysfunction significantly increases mortality. Patients requiring dialysis after surgery have drastically higher mortality rates, sometimes over 60%. Pre-existing kidney disease is the strongest predictor. Protecting kidney function during surgery with adequate hydration, stable blood pressure, and avoiding kidney-toxic drugs is crucial.
Lastly, what medical therapies are essential after surgery, during recovery, and long-term to maintain the benefits in graft patency?
Medical adjuncts are absolutely vital for long-term success. Aspirin is key, usually started within hours of surgery, unless there's excessive bleeding, and continued lifelong to help keep bypass grafts, especially vein grafts, open. Beta blockers are typically started once the patient is stable and off inotropes to control heart rate and blood pressure and reduce myocardial oxygen demand. Afterload reduction with drugs like ACE inhibitors is important, especially for patients with reduced left ventricular function. Antiarrhythmic treatment, often amiodarone, might be used prophylactically or to treat post-operative atrial fibrillation, which is common. And diuretics like furosemide are often used in the early postoperative days to manage fluid balance and prevent fluid overload. Of course, aggressive long-term management of risk factors like cholesterol with statins, blood pressure, and diabetes is also critical. It's really clear, isn't it? The journey doesn't just stop when the patient leaves the operating room. It's a deep commitment to detailed recovery protocols and, crucially, lifelong management and risk factor control. This comprehensive understanding of outcomes, complications, and long-term needs is exactly what drives the continuous effort to refine the existing methods and, importantly, to explore entirely new approaches. Which naturally leads us to ask, what innovations are pushing the boundaries beyond conventional on-pump CABG?
That's a perfect transition. Because surgery is never static, it's always evolving. What are some of these alternative methods for myocardial revascularization that surgeons might consider?
Well, one alternative that still uses the heart-lung machine but avoids clamping the aorta is cardiopulmonary bypass with hypothermic fibrillatory arrest.
A clamp-free approach. Why do that?
It's particularly useful for patients who have a heavily calcified or diseased ascending aorta, often called a porcelain aorta. Clamping such an aorta carries a significantly higher risk of dislodging plaque debris and causing a stroke.
So how does it work without the clamp?
Once a patient is on cardiopulmonary bypass, they're cooled down significantly, usually to around 28 degrees C. As the heart cools, it typically goes into ventricular fibrillation, a disorganized quivering around 32 degrees C. In this state, the heart isn't effectively pumping, but the coronary arteries are still being perfused with blood from the bypass machine. A vent or sump is placed in the left ventricle to keep it decompressed. The surgeon then performs the bypasses on the fibrillating heart, similar to how it's done in off-pump surgery, often using stabilizers.
And the proximal grafts.
If the aorta is too diseased for even proximal grafts, alternative strategies are needed. Arterial perfusion might be done via the axillary artery instead of the aorta. Vein grafts might be sewn onto the innominate artery, or a total arterial revascularization strategy using mammary arteries might be employed to avoid the aorta altogether. After the bypasses are done, the patient is rewarmed and the heart is usually easily defibrillated back into a normal rhythm.
When wouldn't this be suitable?
It's not suitable for patients with significant aortic valve leakage because during fibrillation, the left ventricle would fill up with regurgitant blood, causing distension and potential damage.
Okay, then there's on-pump beating heart bypass. What's the rationale for keeping the heart beating while on the pump?
This is a more selective strategy, sometimes used for patients with very poor left ventricular function, perhaps after a recent large heart attack. The idea is that their severely compromised heart muscle might tolerate the additional ischemic insult of cardioplegic arrest very poorly, even with protection.
So it minimizes ischemia.
That's the goal. Despite our best myocardial protection techniques, cardioplegic arrest always induces some degree of ischemia. For patients with severely stunned myocardium, where getting uniform cardioplegia distribution might be difficult, keeping the heart beating while the pump supports the circulation is considered. The bypass machine offloads the ventricle, providing a safety net while the surgeon works on the beating heart, again using stabilizers like in off-pump surgery. IAVP support might also be considered in these very high-risk cases.
Interesting. Now let's talk about off-pump coronary artery bypass grafting, or OPCA. This avoids the heart-lung machine entirely. It seemed like a really big movement for a while, but you mentioned its popularity has waned, at least in the U.S. Why was it initially developed?
The initial rationale for OPCA was primarily to avoid the potential adverse effects associated with cardiopulmonary bypass, things like the systemic inflammatory response, potential effects on bleeding and coagulation, neurocognitive dysfunction, fluid retention, and transient organ dysfunction.
How common is it now?
It varies geographically. Globally, especially in parts of Asia like India, a very high percentage of CBG operations are reportedly still performed off-pump. However, in the United States, OPC use peaked maybe around 20-23% in the early 2000s, but has progressively declined since then. By 2012, it was down to 17%, and it's likely used in fewer than 1 in 5 patients now in the U.S.
Why the significant decline in the U.S. and some other Western countries?
It's largely attributed to the results of several large, well-conducted, randomized controlled trials that emerged comparing OPC-CAB directly with conventional on-pump CBG. Trials like ROBI, SMART, Coronary, and GOBICADE.
What did these trials generally show?
While they often showed no significant difference in short-term mortality or major complications like stroke between on-pump and off-pump surgery, a consistent theme emerged. OPCB patients often received significantly fewer bypass grafts, meaning potentially incomplete revascularization. And crucially, several trials found that OPCAB was associated with worse medium-term outcomes, including higher rates of cardiac-related death or major adverse events at 1 year, and lower graft patency rates. Even in trials with highly experienced surgeons, the need for repeat revascularization tended to be higher after OPCAB.
So the intended benefits weren't fully realized in the trials.
It seems the benefits of avoiding the pump might have been offset by the technical challenges of operating on a beating heart, potentially leading to less precise or complete revascularization in some cases. And the idea that OPCB dramatically reduces inflammation wasn't fully supported either, as the myocardial ischemia involved in manipulating the beating heart can also trigger inflammatory responses. These findings definitely dampened the initial enthusiasm for OPCB as a routine approach at many centers. It might still be considered a good option for specific situations, perhaps single-vessel LAD bypass in certain patients.
What are the main technical differences when performing OPCB? It sounds much harder.
It is technically more demanding, yes. Since the heart remains beating and ejecting blood, planned and systematic manipulation is key. Both pleural spaces, the linings around the lungs, are often open to allow the heart to be rotated more easily for accessing vessels on the back. More critical areas might be bypassed first. Special stabilization devices are essential.
What kind of devices?
Typically, a specialized retractor system with stabilizing arms is used. One common type has suction cups on feet that straddle the target coronary artery, holding just that small segment still. Another device might use suction on the apex of the heart to lift and position it for posterior targets. Temporary loops or tiny clamps are used to briefly stop blood flow just in the segment being worked on. Close coordination with anesthesia is vital, using short-acting beta blockers to slow the heart rate and vasopressors to maintain blood pressure during manipulation. Postoperatively, the recovery can sometimes be faster, with less fluid retention or inflammatory response compared to on-pump cases.
Okay. What about minimally invasive direct coronary artery bypass, or mid-CAB? Is that related to off-pump?
Mid-cab refers to performing CABG through a much smaller incision rather than the full sternotomy. This could be a small incision on the left side of the chest, anterolateral thoracotomy, a partial sternotomy, or even a subxiphoid approach under the breastbone. Most mid-cab procedures are performed off-pump on the beating heart and typically involve bypassing just the LEA artery, maybe one diagonal branch.
What are the outcomes like?
Meta-analyses have shown pretty good early and midterm results in terms of mortality and graft patency for selected patients. However, mid-cab shares the limitations of OPSI regarding potentially incomplete revascularization if multiple vessels need bypassing, plus its own technical challenges due to the limited access. Long-term comparative data is still somewhat limited.
And then there's the most futuristic approach. Robotics, like totally endoscopic coronary artery bypass, or TCAB.
Yes, TCAB utilizes advanced robotic systems like the Da Vinci surgical system. This allows the surgeon to sit at a console and manipulate tiny instruments inserted through small ports in the chest, viewing the operative field in magnified 3D.
What are the supposed advantages?
Theoretically, robotics offer enhanced dexterity, tremor filtration, magnification, and the ability to perform complex maneuvers through minimal access, potentially leading to less pain, faster recovery, and better cosmesis. TCAB can be performed either on pump, with CPB established through peripheral cannulation, or totally off pump, and multi-vessel bypasses are technically possible.
But what's the reality currently?
The reality is that TCAB is still facing significant limitations. Operating times are considerably longer than conventional CPG. There's a higher rate of needing to convert to a larger incision intraoperatively. It's technically very demanding with a steep learning curve. It's expensive. And perhaps most importantly, robust long-term data on the durability of the bypasses and overall patient safety compared to standard techniques are still lacking.
So it's not mainstream yet.
Definitely not. Even the largest published series reported success rates around 80%, conversion rates of 10%, and very long operative times, with anastomosis times significantly longer than open surgery. There is also a notable rate of injury to the lima graft during harvest. Current limitations include difficulties accessing all coronary territories, challenges in performing multi-arterial grafting robotically, cost, and limited training opportunities. It's likely to remain a niche specialty for highly selected patients and surgeons for the foreseeable future.
What about transmyocardial laser revascularization, TMLR? You mentioned this earlier, for patients with no other options. How does that work?
TMLR is really a therapy of last resort for patients with severe, debilitating angina, refractory angina, who are not candidates for further bypass surgery or stenting, but still have viable heart muscle that's ischemic. It involves using a high-energy laser, often synchronized with the heartbeat, to drill tiny channels directly through the wall of the left ventricle in the ischemic areas.
Does that create new blood flow paths?
That was the original theory, that these channels would allow blood to flow directly from inside the ventricle into the muscle. But that's no longer believed to be the main mechanism. There might be some stimulation of new blood vessel growth, new vascularization, but the predominant thinking now is that it works by affecting cardiac nerves. The laser injury likely damages sensory nerve endings in the heart muscle, leading to a form of cardiac denervation that reduces the perception of anginal pain.
Does it work?
It's associated with reproducible improvement in angina symptoms in a significant portion of patients, maybe 60–80%, showing persistent relief within 6 months. So it can improve quality of life for patients with truly intractable angina.
Okay. And finally, hybrid procedures. You mentioned combining approaches.
Yes. Hybrid coronary revascularization is an integrated strategy that tries to combine the best of both worlds. Typically, it involves performing a minimally invasive lima to L bypass, often via mid-cab or sometimes robotically, combined with percutaneous coronary intervention, PCI, using drug-eluting stents for blockages in the other coronary arteries, non-LED targets.
What's the rationale?
It leverages the well-established long-term survival benefit and durability of the lima to LAD graft, which is superior to any other intervention for that vessel, while using state-of-the-art stents for the other vessels, where the outcomes of modern PCI might be competitive with vein grafts, especially if a full sternotomy can be avoided.
Are there challenges?
Yes. While initial results have been promising, potential pitfalls include higher overall procedural costs compared to either CABG or multi-vessel PCI alone. There are logistical challenges regarding the optimal timing and staging. You do both procedures at the same time in a hybrid OR, or stage them days or weeks apart. And robust long-term outcome data compared to conventional CIB or multi-vessel PCI is still needed.
That makes sense. And one last technical area, Reoperative coronary artery bypass grafting, or redo CABG. You touched on this earlier, but it sounds incredibly challenging.
It absolutely is one of the most technically demanding operations in cardiac surgery. As we said, a significant number of patients will eventually experience recurrent symptoms due to progression of their native disease or failure of their previous grafts.
And the indications are the same.
Generally, yes. If they have significant symptoms or ischemia related to blockages that are amenable to bypass, redo CABG is an option, weighed against the risks and alternatives like PCI. These patients are often older, have more complex disease, and potentially worse heart function than first-time patients. Factors increasing the risk of needing reoperation include not getting a Lima graft the first time, being younger at the initial operation, and having incomplete revascularization initially.
What makes the surgery itself so difficult?
The main challenge is re-entry into the chest through the previous sternotomy. Dense scar tissue and adhesions form after the first surgery, often making the heart, aorta, and previous bypass grafts stick tightly to the underside of the sternum. There's a significant risk of injuring these structures while reopening the chest.
How do surgeons manage that risk?
Meticulous planning is key, often using preoperative CT scans to visualize the relationship of the heart and grafts to the sternum. Sometimes alternative cannulation sites, like the femoral or axillary artery, are prepared beforehand in case emergency bypass is needed quickly. The sternum is opened very carefully, sometimes using an oscillating saw or dissecting structures away from underneath before fully dividing the bone. If an injury occurs, it requires immediate control and rapid institution of CPB. Careful dissection of adhesions is then required before the actual bypasses can be performed. Manipulating old, diseased grafts must be minimized to avoid dislodging clot or debris. Finding good spots on the aorta for new grafts can be difficult due to previous suture lines or calcification. Identifying the target coronary vessels through scar tissue can also be challenging, and the risk of complications like bleeding or perioperative heart attack is inherently higher. Mortality rates for reduced CABG are generally higher than for primary CABG. These challenging reoperations, along with the alternative strategies we've discussed, really highlight how cardiac surgery is constantly adapting to meet increasingly complex patient needs. It's about customizing the care. But let's not forget, sometimes, despite the best interventions, severe complications related to the underlying heart disease itself can occur, particularly mechanical problems after a large heart attack.
Right, the fallout from the disease itself. What are some of the major mechanical complications of coronary artery disease that might require surgical intervention? Let's start with left ventricular aneurysm.
A left ventricular aneurysm is basically a thinned, scarred, bulging area of the heart wall that results from a large transmural myocardial infarction, a heart attack that damages the full thickness of the muscle. It's most often caused by a blockage in the LAD artery.
How common are these now?
The incidence has actually declined significantly thanks to early reperfusion therapies like primary PCI, which limit the extent of heart muscle damage. When they do form, it can happen within days, but it's usually more apparent weeks after the infarct. Many patients, maybe 2/3, remain asymptomatic.
What's the prognosis if someone develops one?
If asymptomatic, the 10-year survival is actually pretty good, maybe 90%. But for symptomatic patients, those with heart failure, arrhythmias, or angina related to the aneurysm survival drops significantly, maybe 50% at 10 years. The main causes of death are arrhythmias and congestive heart failure. The risk of clots forming in the aneurysm and causing a stroke is relatively low, so routine anticoagulation isn't always needed unless a clot is actually seen on imaging.
How is it diagnosed and when is surgery indicated?
It's usually diagnosed with echocardiography. Other imaging, like nuclear scans or PET scans, can help assess the viability of the surrounding heart muscle. Surgery might be indicated if the patient is already undergoing CABG for ongoing angina, if they have a contained rupture or a pseudoaneurysm, which is different and riskier, or if they've had a thromboembolic event despite anticoagulation. Sometimes surgery is considered for severe heart failure symptoms refractory to medical therapy.
What does the surgery involve?
It's often called surgical ventricular restoration or aneurysm repair. The goal is to exclude the non-functional, scarred aneurysmal segment and restore a more normal size and shape to the left ventricle. This is typically done on cardiopulmonary bypass. The aneurysm is open, and often a purse-string suture is placed at the junction of the scarred tissue and healthy muscle. Then, the opening might be closed directly, or, more commonly, a patch made of Docrin or bovine pericardium is used to exclude the aneurysm and reconstruct the ventricular wall. Concomitant CABG is almost always performed. Outcomes are generally good, with relief of angina and heart failure symptoms in many patients.
Okay. What about another serious complication? Ventricular septal defect, or VSD, after a heart attack, a hole between the chambers.
Yes, a post-infarction VSD is a hole that develops in the muscular wall separating the left and right ventricles. It's a rare but devastating complication, occurring in less than 1% of heart attack patients, usually 2 through 4 days after a large infarct, typically involving the LAD territory, interior VSD, or sometimes the RCA territory, posterior VSD.
How does it present?
The classic sign is the sudden appearance of a new, loud, systolic heart murmur after a recent MI, often accompanied by rapidly worsening heart failure or cardiogenic shock due to blood shunting from the high-pressure left ventricle to the low-pressure right ventricle, overloading the lungs.
How is it diagnosed and managed?
Echocardiography is key to confirm the diagnosis, determine the size and location of the defect, and estimate the amount of shunting. Cardiac catheterization is usually performed to assess the coronary anatomy for bypass and measure pressures. The prognosis without treatment is extremely poor, mortality is very high, with many patients dying within hours or days from refractory heart failure.
So surgery is urgent.
Yes, patients who are candidates should undergo early surgical closure of the defect along with concomitant CABG. This is one of the most technically challenging operations in cardiac surgery because the surrounding infarcted muscle is often very fragile and difficult to hold sutures.
What's the surgical technique?
Often, an infarct exclusion technique is used. The left ventricle is opened through the infarcted area. Necrotic muscle is carefully removed. Then, a patch, again usually dacron or pericardium, is sutured securely to the healthy rim of muscle on the left ventricular side of the septum, effectively covering the hole from the LV side. This patch is then often incorporated into the closure of the ventricular incision itself, sometimes buttressed with felt strips to reinforce the fragile tissue. Temporary circulatory support like ECMO or a ventricular assist device might be needed pre- or post-operatively for these very sick patients. Transcatheter closure devices are also emerging as an alternative or bridge in some cases.
Wow, incredibly complex. And the third major mechanical complication, mitral regurgitation, or MER, after a heart attack. A leaky valve.
Yes, ischemic mitral regurgitation can occur in two main forms after a heart attack. There's chronic ischemic MR, which develops gradually due to changes in the left ventricle's shape, papillary muscle dysfunction, or annular dilation caused by the infarct. This is often managed electively with valve repair, usually using an annuloplasty ring at the time of CABG.
And the other one.
The more dramatic and life-threatening form is acute ischemic MR, which results from rupture of a papillary muscle. These are the small muscles inside the ventricle that anchor the mitral valve leaflets. If the artery supplying a papillary muscle gets blocked during a heart attack, the muscle can necrose and rupture, causing the valve leaflet it supports to become flail, leading to sudden, severe, torrential mitral regurgitation. The posterior papillary muscle is involved more often.
And that requires immediate surgery.
Yes, acute papillary muscle rupture is a surgical emergency. Prompt intervention offers the only chance for survival, but mortality remains high, potentially up to 50% in some series because these patients are often in cardiogenic shock. The surgery typically involves replacing the mitral valve. Repair is usually not feasible or advisable in the acute setting due to the damaged tissue and urgency, along with concomitant CABG. Again, these patients are extremely fragile, and the surgeon must be prepared for the possibility of needing mechanical circulatory support, like an LVAD, if the patient cannot be weaned from bypass after the repair. These mechanical complications really underscore the devastating potential of coronary artery disease and the critical need for rapid diagnosis and often heroic surgical intervention. But even within these complex scenarios, and certainly for more routine CABG, patient demographics and comorbidities play a significant role in outcomes and treatment considerations. This raises an important point. How does the approach or expected outcome change for different special populations undergoing CABG?
That's a vital question. Because cardiac care definitely isn't one size fits all. How do outcomes generally differ for patients with diabetes undergoing CKD?
Patients with diabetes, unfortunately, tend to have higher rates of both mortality and morbidity after CABG compared to non-diabetic patients. They often have more diffuse coronary disease, other comorbidities, and sometimes issues with wound healing.
But is CABG still the preferred option for them compared to PCI?
Yes, for diabetic patients with multi-vessel coronary artery disease, the evidence is quite strong. Both the older BAR trial and the more recent FREEDOM trial clearly demonstrated that diabetic patients derive a greater long-term survival benefit from CABG compared to PCI. This benefit is largely attributed to the superior durability of the Lima graft used in CABG, which seems particularly advantageous in the diabetic population.
Okay. What about older patients, say those over 80? Does advanced age alone preclude them from benefiting from CAB?
That's a common question. Approximately 10% of patients undergoing CABG are now over 80 years old. While advanced age is an independent predictor of increased surgical morbidity and mortality, and also predicts a higher likelihood of needing discharge to a rehab facility rather than home, CABG should absolutely not be denied based on age alone.
So it's about overall health.
Exactly. The decision must be part of a comprehensive risk assessment, considering the patient's overall frailty, cognitive function, nutritional status, and other medical conditions weighed against the potential benefits of revascularization for their symptoms and prognosis. But appropriate planning for postoperative support and rehabilitation is essential for this age group.
And for women, are there unique considerations or differences in outcomes? We touched on atypical symptoms earlier.
Yes. While women generally have a lower incidence of CAD than men at any given age, it's still the leading cause of death for women in the U.S. Historically, some large database studies showed slightly higher operative mortality rates for women undergoing CABG compared to men, especially in lower to moderate risk groups.
Why might that be?
The reasons aren't entirely clear, but contributing factors might include women often presenting later with more advanced disease, having smaller coronary arteries, making surgery technically more challenging, potentially having more comorbidities, or maybe differences in biological responses. Interestingly, some analyses of the STS database suggested that women might experience a greater relative increase in risk with on-pump CABG compared to men, whereas with off-pump CABG, their adjusted risks for some outcomes were similar to or even lower than men's. But overall, CABG remains a highly effective procedure for women when indicated.
How does pre-existing renal disease or kidney problems impact the CABG outcomes?
Kidney dysfunction, even mild to moderate renal insufficiency, is a major independent risk factor for mortality after CABG. Patients with elevated preoperative serum creatinine levels face a significantly increased risk, sometimes double or more, compared to those with normal kidney function.
Does CABG still offer a benefit over PCI in patients with kidney disease?
That's a really important question. A large retrospective study analyzing nearly 60,000 patients found that CABG actually provided a survival benefit over PCI in patients with more severe kidney dysfunction, serum creatinine 2.5 milli-GDL. And this survival benefit with CABG was even more dramatic in patients who had both diabetes and significant kidney disease.
Interesting. And finally, what about obese patients? How does obesity affect CABG results?
Obese patients undergoing CABG have a significantly higher incidence of certain postoperative complications compared to normal weight patients. These include higher rates of postoperative renal failure, prolonged time needing ventilator support, and, notably, a higher risk of sternal wound infections. Both extremes of body weight being significantly underweight or obese are actually identified as risk factors for increased CABG-related mortality. Careful attention to surgical technique, wound care, and managing comorbidities like diabetes is particularly important in obese patients.
These insights into special populations really drive home the incredible level of customization and careful consideration required in modern cardiac surgery. It's clearly not just about the plumbing fix. It's about treating the whole patient with all their unique characteristics. What an incredible journey through the complexities of heart health and its surgical management. So, just to recap the key takeaways from our deep dive today. We've really established how pervasive ischemic heart disease is a dominant global health problem with massive human and economic costs.
Absolutely.
We've seen that despite amazing progress in less invasive techniques like PCI, CABG remains a foundational treatment, often the most effective option, especially for complex coronary artery disease.
It definitely holds its ground for durability and completeness.
We've explored the incredibly intricate anatomy of the heart's own blood supply and the remarkable precision and technological support, like cardiopulmonary bypass and advanced diagnostics, that make modern cardiac surgery possible.
The technical aspects are truly astounding.
And we've emphasized the critical importance of that multidisciplinary heart team approach and highly individualized patient assessment, considering comorbidities, syntax scores, specific clinical scenarios to determine the absolute best revascularization strategy for each unique patient.
Personalization is key.
And finally, we touched on the constant innovation, the ongoing evolution of techniques from minimally invasive approaches in robotics to hybrid procedures, showcasing this field's relentless commitment to improving patient outcomes and adapting to ever more diverse and complex needs.
It's a field that never stands still. If we connect all this to the bigger picture, this whole journey of heart surgery, from those very rudimentary early attempts to today's highly sophisticated interventions, it really reflects humanity's relentless drive to understand and overcome disease. It makes you wonder,
What's that?
well, given the incredible speed of advancements in fields totally outside traditional surgery, things like gene editing, artificial intelligence playing a bigger role in diagnostics and prediction, maybe even tissue engineering, could we one day move beyond bypasses and stents entirely? Could we reach a point where we can truly regenerate damaged heart tissue, effectively making acquired heart disease a curable condition rather than something we just manage?
Wow. A truly thought-provoking question that really pushes us to imagine the future of cardiac health moving from repair to regeneration. Thank you for joining us on this deep dive today. We hope you feel much more informed and perhaps just a little more amazed by the wonders of the human body and the incredible medical ingenuity dedicated to preserving it.